Okay, we are live.
Those.
Start.
Good evening, everyone. So this is the third masterclass of the second season, the fertility. Don't smile. This is an important class because this is very relevant for this time and age. And we are talking about the anti-obesity drugs like Ozempic and Mounjaro and how it is useful in fertility treatment. So these drugs were typically used for diabetes mellitus, and then the off-label usage for this fertility treatment started. And many of the fertility experts and patients request whether they can use these drugs. So today we will discuss about whether they are safe to use, how frequently they should be used, what is the dosage, how whether the fertility specialist can directly start prescribing to anybody, or how we should actually start using them so that we can optimize the fertility treatment for patients who are definitely in need of these. These are, I think, Mounjaro is the highest selling drug as in the Indian market currently, and it is, I think, one of the wonder drugs after insulin and probably Dolo and after COVID vaccine that has ever emerged. And this is the most talked about drug. These are the drugs which are very, very often discussed over the social media, Instagram. People come under this influence. It is such a common thing for everybody to talk about it. The life coaches, nutritionists, even the gym, the consultants, so many people just use it just like that. So in our field of reproductive medicine, whether it is really something which is valuable, or are we just like, trying to use these fancy drugs just under pressure, we will know today. So a few practical aspects will be discussed, and as these are very new drugs, we are clear about how they have to be used, but still there are more data which needs to come in with these drugs. Yes, you can take over.
So, first things first, you will get representatives from both the companies to come and meet you as a gynecologist to make sure that you are at least giving and sounding off these drugs to your PCOS patients. That is for sure, right? But remember one medico legal piece of advice: do not prescribe these drugs on your own. Please send the patients to your physicians or your endocrinologist or your bariatric surgeons, one of the three, anybody of your choice. If in case you are working in a multi-speciality hospital and if you have an obesity clinic, that is even better. You can have a multidisciplinary team there, and then let them do whatever they want to do as far as Ozempic and Mounjaro is concerned. Okay. Uh, very, very briefly, both of them, do something to the gastric mechanism like GLP-1 and all those types of molecules. No point getting into it. Both of them are injections. Both of them need to be continued in subsequently higher dosages on a weekly basis. And then there is a maintenance dose which is required continuously. So you cannot really take these drugs for, like, let's say 2 weeks and then say, "Okay, oh, it was beautiful." Then you will again blow up like a balloon after the next 2 to 3 weeks. This is exactly what happens if you discontinue the drugs midway or do not take the maintenance regime of these drugs. Okay, so that is the first thing. I also want to tell you very explicitly that if in case you end up speaking to a bariatric surgeon or an endocrinologist, they do not randomly prescribe these drugs to people. We were just discussing this before the class started. They are going to go through this entire situation of BMI and fat index, and then they are going to study your liver and look at the upper abdomen ultrasound and make sure that you do not have any pancreatic or GI complications before they actually prescribe some drugs. They may also want to look at your other complications like associated comorbidities like blood pressure, diabetes, nephrotic syndrome, before they may want to make a choice as to what they want to give. Okay, but then I think some people like one thing, some people like the other thing, but ultimately both the drugs are really fast selling drugs. Okay, is what probably you can say. And the effects are, uh, for the people in whom it is working, people end up losing like 12, 13, 15 kgs in like 6 months. Okay, so this is something which even I have seen in PCOS patients, people who are resistant PCOS patients. Okay, resistant, I mean, you have done everything, they are working out from morning to night, not a drop of weight was going down. Okay, but after these two drugs have come, these people have suddenly started to lose 10 kgs, 15 kgs weight. God knows how. how. Okay. But again, I'm not an expert into endocrinology of these drugs. So I don't think I'm the best person to comment, but definitely there are results. So there is no question about that. Okay. Now coming to the fertility aspect. How do you actually manage these patients who are taking these drugs? So first remember one thing. If in case a patient is on any of these drugs, one golden line, no fertility treatment to be done. Okay. No IUI to be done, no ovulation induction to be done, no IVF to be done, no egg pickup to be done, no embryo transfer to be done, no pregnancy to be done, no natural intercourse, no timed intercourse, no follicle monitoring. If the patient is on any of the anti-obesity drugs, this is even extrapolated to Orlistat. Orlistat is that drug which you take orally, 60 mg twice in a day. Quite a lot of patients, then report with passing very discolored stools. Okay, in all these types of situations because the fat absorption goes down because of taking Orlistat. And even on Orlistat, you are not allowed to do IUI, IVF, natural conception, and any of these things. But what happens if somebody has gotten pregnant? Now what? Okay. If somebody is taking semaglutide and patient is pregnant. So the answer is very simple. Refer the patient to perform to do MTP at a nearby center where the person is doing MTP. I don't do MTPs. I don't have a license, but I have had this situation in the past where we have had to refer patients when somebody has taken Ozempic, does not know only PCOS patient, any which way was not getting periods on Ozempic, realized that her weight loss has happened, also had intercourse. All these things have happened, and the patient is pregnant 4 weeks, 6 weeks, all these types of things. Okay. And you really need to do an MTP because there is no data which is available at this moment. But on all these drugs, it is a warning that you should not be taking these drugs when you are trying for pregnancy. You should not be taking these drugs when you are pregnant. Okay. That is for sure. There is a reason for all this because these drugs are known to go and interfere with the general metabolism and the general immunity. So whenever you are trying to pitch in pregnancy, pregnancy is an immunomodulator state, and we exactly do not know the amount of interface it is going to have at the endometrium level. Because we do not know that, that is the reason why we do not prescribe these drugs even when you are doing follicle monitoring. So there is a logic behind all of this. Just remember one more thing. If in case you are taking these drugs, there is going to be no problem in the ovulation. So ovulation will occur nicely only. In fact, in people in whom ovulation is not occurring, ovulation will start to occur because of these drugs, because these drugs also have a fabulous insulin sensitivity response. Okay, they will make the body extremely from insulin resistant, the body starts to become insulin sensitive because of these types of drugs. So for people who are with chronic PCOS not ovulating, okay, this can help them start ovulating and start getting periods, and I've seen that in patients. The only thing is it is a very expensive way to get periods because just taking these injections for a month is going to cost the patient somewhere in the range of around 16 to 25,000 based on the deal which they get compared to taking Mepret, which is 5 rupees. So it is a little expensive part as far as that is concerned. Simultaneously, we have to make sure that no matter what the patient tells. See, the commonest thing which patients have started telling now in practical life situation is, I'm already taking Ozempic. Doctor has told me to wait for 3 months after I stop Ozempic and then you do embryo transfer. Why don't you at least do stimulation? Okay. You should not do stimulation in these patients. The reason why you should not do stimulation in these patients is because you do not want any type of other complications to occur when the patient is on these drugs, because the broad spectrum responses of these drugs towards the vascularity, towards the pelvis, towards the gut, towards the pancreas, towards the liver is still not completely understood. And there is no point taking these drugs and trying these drugs because any which ways, remember one thing, most of these patients are going to be on the very obese side of life. Okay. We also do not know how is the interaction of these drugs with the anesthesia drugs. So the anesthetists are also very scared. If you go and talk to your anesthetist, there is no PSC given to a patient who is on Ozempic. There is no PSC given to a patient who is on Mounjaro. There is no PSC given to them even if they are scheduled for any other surgery. Okay. The endocrinologist has to write down, the endocrinologist has to stop these drugs. And when the endocrinologist is stopping these drugs, that is when they are getting clearance. At least this is what I have seen so far. Um, as far as my limited interaction with these drugs in clinical situations are, I have also seen one situation where these drugs, no, they grossly reduce sort of the appetite or the amount of food which the patient can take due to whatever things. So people are also hesitant to do supra major surgeries on these drugs because the nutritional status of the patient has gone down. And because the nutritional status of the patient has gone down, any post-operative complication, just in case it occurs for the patient on these drugs, then it can be very, very traumatic. Okay. There is nothing called as you stop the drug and you start the treatment. You need to stop the drug and you need to start the treatment after 12 weeks. That is 3 months. There is nothing which is faster than that. Okay. What probably we can do is for the patient in whom there is extremely poor oocyte quality with a heavy BMI more than 28, 29, correct? In those situations, if the patient wants to improve their vitality and egg quality, they can take these drugs, continue taking the drugs for at least a year, reduce quite a lot of their weight, stop the drug for 3 to 4 months, like how we ask in methotrexate, stop for 6 months. Stop these drugs for 3 to 4 months and only then start ovulation induction till further data becomes available to any one of us. Till that time, do not make that mistake of trying anything fancy as far as these drugs is concerned. And this is not just my advice, this is written straight on the package insert of these drugs, which is available. Okay. So with that, probably I want to conclude. Definitely no role, no role of continuing the pregnancy on these drugs. 100%. No role of embryo transfer. No role of doing egg retrieval and no role of doing stimulation. No role of giving letrozole. So not applicable for level 1 and level 2 clinics both.
But I will tell you, I mean, I use Mounjaro a lot. It is a
Yeah.
fantastic drug. Fantastic means it's one of, I think it's a wonder drug. So patients, we start with usually 2.5 under physician guidance, and then we go on escalating to 5 mg and then do the maintenance dose depending on their BMI and what is the weight loss that is required. So usually we plan it over a period of time. So say like 9 months.
Six
So
months.
the 6 months will be only on these drugs where they lose about 10 to 12 kilos, and it is started only if their BMI is above 30 and not below that, or if they have had and with PCO, obese PCO, or if they have had previous IVF failures, which in spite of, like, having probably like embryos, and then it is not working because of the inflammation of the endometrium. So for 6 months they will be on the drugs, then we give break of 2 to 3 months as you said, and then we start with the stimulation. So we have not seen much improvement in terms of, like, getting more euploid embryos, or we have not seen increase in the pregnancy rates as such, though the number is very small as of now. But their weight loss and the compliance for fertility treatment is superb, because as working women, like many of them are like, office workers or like software engineers, BPO workers, asking them to lose weight with their intense career demands itself is like, I feel it's a torture for these working women. So these are alternatives. Of course, this is not a substitute for lifestyle changes like diet and exercise, but it is an excellent drug. Only thing, as you said, is the
It is temporary. The thing is,
temporary.
it is excellent but temporary. That is the thing.
Temporary. And the nutritional aspect of it. So nutritional aspect is like they are deficient on B12, they're deficient on many things because they cannot eat. And
Yeah,
their initial 1 week is like horrible. So many a times they think of giving up in that initial
yeah.
1 week, where they have so much of bloating, they have gastritis, they have severe nausea, and they have loose motion. So it will take at least 1 week for that drug to get adjusted, or the body to get
So
adjusted to that drug.
from what I know is most of the endocrinologists or bariatric surgeons or whomsoever, they always also recommend a diet plan with this.
Yes,
Okay.
yes.
They will
Nutrition management, yes,
there is a nutrition management which is mandatorily to be done. Like there is, I mean, at least I don't give it at all. I just send it to the endocrinologist to give it, but I have never seen him giving it just as an injection. It is always with a sort of a weight loss plan that along with that they are planning to give this.
yes, yes, very true. So do you recommend this in lean PCO patients who are the most difficult to treat?
What, madam? What will be left inside?
I'm sorry. Arre, these are questions on Chat GPT. You cannot say that.
No, so I don't recommend.
Okay, thank
Their
you.
BMI will be 2, madam. The recommendation for BMI is 22, I mean, to 32 or 27 and above.
And what do you think? I mean, do you think their endometrial receptivity will be better?
No.
And do you do any sort of monitoring in terms of like hormonal values? Because sometimes there can be hypothalamic suppression in these cases, and they may continue to have anovulation. So, do you want them to get their periods before you actually start the stimulation, or you just start it at 12 weeks,
So,
stopping?
uh, so best is to stop for 12 weeks, as I said.
Yes.
This 6 to 8 week window is where there is this menstruation which occurs if the menstruation has not occurred. This is what I have seen. Okay.
Mm.
Otherwise, I'm telling you, they will have regular menses. Trust me. The menses do not go down for people who are on regular menses. Some of them will end up complaining that the flow is much better, or the flow is much lesser, rather, not much better. And that's about it. I have never, otherwise, see, the data and the drug availability in India is probably less than a year. Okay. On a widespread level. So beyond that data, even I don't have. But I've seen people thinking that array 6 months have gone beautiful, stop the drug, nothing will happen. And in 6 months, another 6 months, they are back to where they were, you
Mm.
know. So the problem with, from what I understand, the problem is that it is lifelong. That is a sort of a problem, It is not a quick, it is a quick fix for a
Mm,
temporary something.
mm.
Mm. Yeah. So, yeah, that's all. So,
I
do you have any questions?
yeah. So we spoke about these drugs in the female, but what about in the male, Jay? Because
Same, ma'am.
so many
Nothing
men who
happens.
are
See, the problem with male fertility is very unique. If you have excessive estrogen exposure to a testicular environment, which has occurred in obesity any which ways, in obesity, because of peripheral fat which is present, testosterone does get converted into estriol, which goes and acts over the feedback loops, and it thereby causes a subtle hyalinization change as far as the seminiferous tubules, which is irreversible. Okay. So even if you undergo bariatric surgery, and you lose 45 kg weight, your sperm factors will still be poor. Even if you have non-obstructive azoospermia and you undergo bariatric surgery, you will continue to have non-obstructive azoospermia because estradiol has acted on the sperm for a very long period of time. Now, the thing is where we try to say that, okay, but in diet and modified and lifestyle changes, when there is weight loss, the sperm factors go up. That is what weight loss? 6 kgs, 7 kgs, 10 kgs. Okay. When somebody is 80, see, an average male is going to weigh around 80 kgs. Okay. From 80, if he becomes 72, that is a 10% drop in his weight, which is any which way it was going to happen. Understanding the minute, this restriction, that restriction. Here you are adding this drug to have a very rapid
weight loss.
fall of weight. And that rapid fall of weight, testosterone will stabilize. But the change which has happened over the testis because of chronic overexposure of estrogen is not going to settle down, madam.
No, so if the man is taking this drug, like how you ask the
It
woman for
it
a
won't come,
washout
it
period,
won't necessarily improve his sperm quality.
agreed, agreed. But then, like if the patient is taking this drug, we say no pregnancy, no IVF, no transfer. You've made this clear.
Yeah,
So similarly, when a man is taking it, can we do the IVF, treatment? Does
of
it have
course.
effect on the
Not
DNA
at all.
quality?
Not at all. Not at all.
A man taking Ozempic, no contraindication for IVF, but a
Yeah.
female taking Ozempic, contraindication for everything from ovarian stimulation to
I will
trying to.
tell you why. There is an answer to this, madam. I'll tell you why. Because when a man is taking it and when you are doing a fertility procedure, you are doing something called a sperm wash. Okay. So majority of the discrepancies which are going to happen in that no are then remaining only at the molecular level for a washed sperm.
Hmm.
Okay. And nobody at this moment knows the effect of Ozempic on molecular aspect of spermatogenesis. Nobody knows it. So that is why there is no contraindication.
Right, right. Um, yeah, I think I'm done. So
Yeah.
your message is quite loud and clear. No giving these drugs in the female at all.
No role.
Yes, who are trying for fertility.
No role when you are trying for fertility.
Okay.
Sure. Yeah.
Yeah.
Thank you so much.
Thank
It
you.
was good. I think these are the topics that now we have to discuss so that many people can understand the complexities of the cases that they can face in their fertility